Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is Landry Slaughter, a PGY2 critical care resident from Vanderbilt University Medical Center, who will be presenting optimal vasopressin initiation in septic shock, the OVISS reinforcement learning study.
Thanks for that introduction. So to jump right in, we'll get started on some background. So for septic shock, first-line vasopressor is norepinephrine, which is recommended in our Society of Critical Care Medicine guidelines for patients who cannot maintain a mean arterial pressure of greater than 65. For patients who persistently have a MAP less than 65, the recommendation is add vasopressin instead of escalating the dose of norepinephrine. Vasopressin is an endogenous peptide hormone that's produced in the hypothalamus and stored and released by the posterior pituitary gland. There's multifactorial production of vasoconstriction with the administration of vasopressin. It binds V1 receptors in our vascular smooth muscle, which is going to increase our arterial blood pressure. It also binds V2 in the kidneys, which results in fluid reabsorption and increasing blood volume. All of this together, among other mechanisms, are going to increase our arterial pressure. Some trials that have sought to evaluate vasopressin's role, first beginning with our VASS trial, sought to evaluate patients with septic shock admitted to the ICU on low-dose norepinephrine. And they randomized these patients to low-dose vasopressin or norepinephrine in addition to open-label vasopressors. And they found that low-dose vasopressin did not reduce mortality rates when compared to vasopressin. Lower mortality seen in this study between 35 and 40%. So it was underpowered to detect a true difference. MAPs at the initiation of vasopressin were also greater than 65. So I think that just led to some limitations leading into the VANISH trial in 2016, which sought to assess the effect of early vasopressin versus norepinephrine on renal failure, 409 patients with septic shock in the ICU. And they found that the early use of vasopressin did not improve the number of renal replacement-free days. And then the next study that really tried to address our vasopressin timing is a single center retrospective cohort study conducted in our MICU here at Vanderbilt with our pre-cohort study receiving vasopressin at 10 micrograms per minute compared to 50 micrograms per minute. And they did not detect a difference in the time to reach goal mean arterial pressure between the two groups. Delay in vasopressin initiation, again, resulted in no difference, 2 hours versus 1.3 hours. And so the OVISS study objective was to derive and validate a reinforcement learning model to determine the optimal initiation rule for vasopressin in adult critically ill patients receiving norepinephrine for septic shock. The methods of this study are very complex, so just stick with me here. So this was a retrospective observational study utilizing a reinforcement learning model. So they evaluated adult patients in their first septic shock episode admitted to the ED, emergency department, or the intensive care unit receiving norepinephrine that had enough data in their EHR. They analyzed 4 different cohorts. They did their testing of the model on a portion of the UCSF cohort. And they utilized sepsis 3 criteria for diagnosing patients with septic shock. So infection, concomitant organ dysfunction as delineated by our SOFA score greater than 2, hypotension requiring vasopressors, and an elevated serum lactate. And so what is this reinforcement learning model and why did they use it? So to learn the optimal timing of vasopressin, to integrate complex and time-varying physiological signals, which we'll talk about what these were. But I mean, patients are different from minute to minute, especially when they're sick like this. And so kind of incorporating all of that together. Optimizing survival and organ function and providing individualized dynamic treatment guidance beyond static clinical rules. And so this reinforcement learning model utilize Markov decision process, which formalizes decision-making under large uncertainty, utilizing a number of parameters. And so I'll spare you the mathematical calculations at each 1 hour time point, but they used 1 hour time blocks or 1 hour epochs. They had a binary choice, so initiate vasopressin or do not initiate vasopressin at the end of that 1 hour mark. And then they used a reward function. And so, for example, +1 for 1 hour of survival, -20 for in-hospital death, +1 for lactate increasing, +1 for MAP rising, +3 for SOFA score decrease, and +1 for reduced norepinephrine use within that 4-hour period. So with this, they ran some descriptive statistics to characterize the groups. They used weighted importance sampling to estimate how the outcomes would change under the reinforcement learning model. They used causal modeling using a logistic regression to evaluate mortality. Further statistical analysis that were done using a confounding assessment to test for causal plausibility, sensitivity analysis to reveal model fragility, and model fairness using Shapley additive explanation values, which we'll kind of break down when we get there. So their primary outcome would be in-hospital mortality, and secondary outcomes need for kidney replacement therapy or need for mechanical ventilation. And so breaking down the results of the study, the average patient in this study across the cohorts was on average a mid-60s male with a Charleston comorbidity index score between 2 and 5, or less than 10, or a score of 4 would predict a 10-year mortality of 53%. In evaluating the different cohorts at their clinical presentation, mainly by vital signs and initial assessment, you can kind of see that they vary a bit between the cohorts, but largely a patient that we would be worried about with an elevated heart rate, a lower blood pressure, elevated respiratory rate. These patients largely were afebrile, GCS between 10 and 12, and then a SOFA score between 4 and 5. A SOFA score less than 9 is going to predict less than a 33% mortality. So we're worried about these patients. Going into their biological results, you can see that their white blood cell count across the cohorts were greater than 12, but specifically evaluating their lactate, only the UPMC cohort had a lactate greater than 2 as their median. Looking at organ support, you can see our doses of norepinephrine are different between the cohorts. I think clinically relevant in the EICU cohort compared to the UCSF cohort that had significantly less norepinephrine being provided. And then vasopressin being introduced in these cohorts ranged between 20 and 48%. So definitely something to consider. So looking at some of our different outcomes, baseline characteristics, comparing the clinician observed action in our reinforcement learning role, starting with vasopressin being initiated. So the clinician observed action for vasopressin initiation occurred in 31% of patients across the cohorts. But when comparing that to the reinforcement learning role, they actually recommended initiation in 87% of these patients. And so they did find a difference there. Additionally, with the median norepinephrine dose significantly higher in our clinician observed action compared to our reinforcement learning rule. Time since shock onset at which vasopressin was initiated, 5 hours in the clinician observed compared to the learning rule, which was 4. SOFA scores and serum lactate, also leaning to the fact that the reinforcement learning rule recommended vasopressin earlier in the patient's clinical course before they were more sick. So their primary outcome in hospital mortality occurred in 41% of patients. Adjusted odds ratio of in-hospital mortality were lower if vasopressin was initiated similar to the rule compared differently. And they found this across each of the validation sets. This e-value of 1.46, an e-value is used to assess the sensitivity of an association to the influence of the unmeasured confounding. So an e-value of 1.46 for in-hospital mortality indicates an unmeasured confounder would need to increase both the reinforcement learning rule matching with the clinician observed action and mortality by 46% to eliminate the observed effect. Our secondary outcomes, 19% kidney replacement therapy, again, concordance with the model would improve this, and mechanical ventilation at 53%, and they didn't necessarily find a difference here with the adjusted odds ratio of 1. Our off-policy evaluation using our weighted importance sampling, the reinforcement learning model was associated with higher overall reward, as well as for each of the individual components. So your patient, if you applied the rule, your patient would do better, is essentially what this says. And it broke down in each of the different components as well, including in-hospital mortality, mean arterial pressure, SOFA score, norepinephrine dose, and serum lactate. The next box down with our internal validation in the UCSF cohort. So this was the cohort they trained the model on. And so they didn't actually find a difference in this cohort that they trained the model on, indicating likely that they needed a bigger population to see this difference with. And again, they detected that the model was superior in each of the external validation cohorts. Causal modeling using weighted pooled logistic regression. Essentially, these words in these lines, concordance blue indicates that the clinician observed action equaled what the reinforcement learning model recommended. And so concordance with the reinforcement learning rule in each of the time blocks was associated with decreased odds of in-hospital mortality at each time point. And they found that this was significant. The authors indicated that their study was robust to confounding. ICU and hospital level analysis was performed, and they found concordance with the reinforcement learning model improved in-hospital mortality. Falsification analysis was also performed, in which they utilized the reinforcement learning model to assess negative outcomes and a negative exposure and its association with mortality. So a negative outcome meaning death occurring, and then a negative exposure would be introducing vasopressors 2 hours after shock onset compared to like that 1 hour mark. And concordance with the reinforcement learning model and the negative outcome had a higher adjusted odds ratio, and then negative exposure and mortality again had a higher odds ratio of mortality. And so they did these shapely additive explanations, or SHAP, SHAP values, to elucidate the impact of individual clinical features on the reinforcement learning model's decision making. And so the values that they assessed had the most impact on the model were time since shock onset, SOFA score, norepinephrine dose, and serum lactate. And so with that being said, did any of these one components generate a significant effect on the model? And so when they ran this reinforcement learning rule and they tried to make more simple decision rules for initiating vasopressin, they found that they were not statistically significant for in-hospital mortality, indicating that initiation of vasopressin is likely more complex than just assessing one component of a patient's clinical picture. Again, they did these shapely cohorts, and in the sensitivity analysis, the model performed very similarly among patients, among the restricted cohorts of patients in whom vasopressin was recommended or initiated within 48 hours. Other sensitivity analyses that they performed found increased odds ratio for in-hospital mortality that were not statistically significant. So, for example, they varied gamma, which is a component of the reinforcement learning rule that impacts future versus immediate reward. So the patient survives within this 1 hour time block compared to the patient survives at the end of their hospitalization. And they didn't find any difference when they varied their gamma. They next utilized 2 hour time epoch rather than 1 hour time epochs, and they found increased odds of in-hospital mortality. And then they used an alternative weighting for each of those components. So like we talked about earlier, +1 for surviving the hour, -20 for dying within that hour. And they saw increased odds of in-hospital mortality. They additionally stratified the model by sex, race, and age, and didn't see a difference when they varied any of those. And then the author's conclusion were that vasopressin, like we saw in those baseline characteristics, largely varied with the clinician observed action, probably indicating a variance in each of our practices at our own institutions. They concluded that the reinforcement learning model developed and validated with observational data sets recommended more frequent and earlier use of vasopressin than observed practices and was associated with reduced mortality. So what does that mean for us? I think that the study was large and included a diverse data set, and they attempted to conduct robust validation. They had appropriate uses of all of their off-policy evaluations, and I think that they assessed clinically relevant outcomes such as in-hospital mortality, kidney replacement therapy, and need for mechanical ventilation. I think the large limitations of this study are obviously the observational design of it, and that it's a reinforcement learning model rather than clinical actions. Like I said, again, the reward function is very arbitrary. Of course, death is going to be greater than surviving the hour. The time distinction of the 1 hour blocks. I think, again, many things can change in 1 hour for a patient. They didn't include any dosing or weaning of the vasopressin with their model. And so I think that would be something that would be interesting to see in future studies. And again, the model may very well be detecting the patient's severity of illness. And I think that we're missing a couple of key clinical variables that are included in this study, weren't included in the study. So my conclusion was that this study may help identify a potential sweet spot for patients' earlier vasopressin use at lower norepinephrine requirements. But again, with the observational nature and the learning tool that was utilized, I don't think we can apply this to clinical practice. So I think we do need further studies to be conducted before we make any practice shifts. And with that, I am happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.